All right, so let's propose to begin at 10 minutes past 2, so that we can take this time to also just reach out to our other colleagues to join. We'll begin at 10 minutes past 2. Thanks. All right, so I think we can begin because of time. Good afternoon, all. Let me take this opportunity to welcome all of us into this call. Remember, we had our inaugural webinar a month ago, exactly a month ago, and we had promised that we will be having recurring webinars every month. And today, at our first webinar, we were discussing about PMTCT. So today we'll be discussing about how we can take advantage or harness machine learning, especially for us at the front line, especially the service providers, in predicting analytics for preempting IITs, so that we can act early enough rather than just waiting till we lose them. Then we start looking for our clients once they are lost. So that's just a preamble of what we will be presenting on today. Before then, I want to just recognize a few of our colleagues who are here. Dr. Lily is not able to join us. And I would wish that I'll give them an opportunity to just make a few remarks. I don't know whether we have anyone from DOD, anyone from DOD to just say hi to the team. Anyone from DOD? Okay, I guess they're still joining. We'll give them an opportunity once they join or towards the end of our webinar. Anyone from USID?
Thanks, Songua. Can you hear me?
Yes, I can hear you, Lydia. Go ahead.
Okay, good afternoon, everyone. So my name is Lydia Odero from USID, and happy to join the team. Thank you.
Thank you very much, Lydia, and we really appreciate your time and for just taking time to join us in the call. Anyone from CDC? I think I've seen Dr. Agnes. I don't know whether there's anyone else. Dr. Agnes, probably maybe you can say hi to the team and anyone else from CDC. Dr.
Good afternoon, everyone, and thank you for joining this call. And to Franklin and Tim, thank you for just taking your time to take us through this webinar. Thank you.
Thank you very much, Doc and Karibu. All right, so county, I don't know whether we have any Casco in the house to just speak on behalf of the county teams. Anyone, any volunteer? May not really be able to run through the whole list, but any Casco is in the house can speak on behalf of the Cascos. Any CHRIO? Okay, just give me a minute. Okay. Right, so yeah, I guess they will join us, but we can then go ahead. Like I said earlier, apologies from Dr. Lily, who is our lead SI. She is engaged in another meeting, so she's not able to join us. But Dr. Lazarus is here to represent the care treatment team. So remember, we always attempt to do this jointly. I want to request Dr. Lazarus to speak on behalf of the NASCOP team. I'm not sure whether Dr. Caro is in, but Laz, if she's in, you can also welcome her. Dr. Laz, over to you.
Thanks, Frank. Dr. Caro is not on the call, but my name is Dr. Lazarus Mimaji. I work at NASCOP as a TA care and treatment. So we are happy to join this call. I think the discussion we're having about interruption in treatment and how best we can be able to leverage on technology to identify those people who are likely to interrupt treatment and therefore be able to put interventions in place to be able to minimize the disengagement from care. Yeah, I think from our end, we've been having a lot of discussions around also targeting this group in terms of screening for advanced HIV disease. So we know that when people interrupt treatment, they're also likely to come back with very low CD4s and also with opportunistic infections and even progress to mortality. So I think we are excited to be part of this call and we look forward to the discussions. Thank you, Frank, and back to you.
Thank you very much, Laz. And we also appreciate the fact that you're able to create time to join us. Remember, we do this for the programs, and your presence is really, really appreciated. Because at the end of the day, we'll need to come up with action points, and those action points should be followed up when we make sure that whatever we've agreed on is acted upon, so that we can leverage, like you've said, on technology in terms of plant management, and more so now that we'll be talking about IIT, we predict and identify clients who are likely to drop off treatment and provide the necessary care and support to keep them in treatment or on treatment. So without much ado, kindly allow me to welcome Dr. Mudoka, who will take us through the presentation. I'll request the teams, in case you have any questions, just use the chat. You can post on the chat. We have a team who will be available to respond to any of your questions. So, Dr. Ari, you can take it up, and we'll have a Q&A towards the end. Once Dr. Mudoka is done with the presentation, we'll also give you an opportunity to ask any questions or any clarifications. So, over to you, Dr. Ari.
Thank you, Sam. Please confirm you can hear me and see my screen.
Okay, I can hear you loud and clear, and I can also see your screen. Proceed.
Thank you very much. So allow me to take the next 30 minutes to just take you through the ML and how we can leverage this to be able to preempt IIT. Please, if you're able to mute, please mute. So I think the areas that we'll cover today, just a brief introduction. We'll share some data on how appointments have been based on data submitted to the National Data Warehouse, which has been part of the wider support to the IFADI initiative. I will outline the process of how we developed and deployed the ML model and as well as the integration and what you see in the line. There has been challenges reported by various facilities and service delivery partners. So I'll be able to just highlight what we are doing about this, and then just a few next steps on what we intend to do. So to begin with, we all know that the main challenge with treatment continuity is caused by IIT, which slows the gains that you get with the high coverage for ART that we are seeing. And that in many programs, it's very difficult to preempt who is likely to be IIT and who is not. And most of the times we end up making the intervention already when the patient has already, or the client has missed an appointment. So what we end up doing in our current clinical practice is that we probably end up giving a standard HIV care for every, appointment or clinical encounter, regardless of the risk of this client missing an appointment. There had been several attempts for manual tools to be able to identify who is likely to be IIT, and especially in facilities that you don't have many patients, clinicians can become very good at at identifying people who are likely to miss an appointment based on some of the information or based on the experience. But this is not as standardized for larger facilities, and we're likely to make mistakes when we do this manually. We end up sending SMS reminders to everyone. We don't end up targeting those who are likely to miss an appointment. And like I said earlier, most of the effort will begin when the client has missed an appointment, and sometimes this is a bit too late for intervention. From the HIS perspective, there's quite a lot of features that support retention, from the way of preventing it before it occurs, to supporting, accountability once someone misses an appointment, or even tools that support us to be able to understand some of the patient perspectives on appointment keeping. For instance, for preventing IIT, we have a very robust module in Kenya EMR, and I know even the other EMRs out there, they all have appointment management. We have Ushauri and Nishauri that we can leverage to do appointment reminders. Today, our focus is on how we can leverage on machine learning, and we already have a report and alerts that I'll share shortly at the EMR, and also clinical decision support features that usually help a facility to just identify before it's too late, before IIT has happened. To be able to support if someone has missed an appointment or is IIT. In the EMR, we have a default tracing form and a register. We have the Ushauri tracing module and some reports like the appointment and attrition report, and also the TX card report, where you can be able to compare two TX cards and you can identify a line list of patients who are present last time and they're missing now. And you can use these to know who's IIT, and you can be able to track this. We did present at some point about the ART directory and how it can help us to account for the transitions and those who are being transferred out. And the recent features around mortality audit that help us understand, who is likely to die or who is dying, so that we can be able to tailor our management. And the very many use cases for P-survey. I would also mention that at some point we'll be sharing some of the results based on P-survey for transfer outs and IIT clients who have returned to treatment, and some of the insights we are getting from patient perspective. So there's so much you can be able to do, and I'm very happy to see partners using this tool to be able to understand perspectives of the patient. So as a way of more background, to just look at the magnitude of the issue, we looked at the data for uploaded in March 2024, and we looked at all appointments that were given up to January to just see how many of these were kept and how the appointment keeping analysis results look like. And what we see is that when you look at this, about 70% or thereabout of appointments are kept, meaning either people come on time or about half of them, but a smaller proportion also come before the appointment. There are some who miss appointments, and the facilities are doing quite good to be able to prevent IIT. Between missing appointments between 1 to 30 days, you can see that majority we are able to trace and bring them back within a week. And about 20% of IIT is prevented. but close to 7%, of IIT still ends up happening. And even though we managed to bring some back within, within a month or 2 months, we still have a proportion that is still IIT, about 3.7%, 2 months and beyond after the appointment has lapsed. Over the years and over the months, we have reduced the lost in HMIS, and maybe for those who may not relate to this term, the lost in HMIS, we define this as those who were given an appointment and they are supposed to have come back, but the facility has not uploaded data to the warehouse for us to be able to determine whether the appointment was kept or not. So for now, the number is very small, about 0.2%, 0.3%. So those ones, we consider them lost in HMIS, and I'm hoping over time this number will be able to reduce to 0. But overall, what we can see is that about 80%, 85% are, when you account for those who kept appointment and prevent dieting, we're able to keep them on treatment. When you look at the IIT with the national target of less than 1%, we started from around sometimes July 2022, close to 6%. It's been up and down like you would expect with any other public health initiative. There seems to have been a surge to 3.7, 3.8, sometimes in January. And we hope maybe in the next analysis that this would continue with a downward trend to where we had seen sometimes towards the end of towards the end of September 2023, that will continue with a downward trend. When you look at the data by partner and county, we see differential performance. So you see some counties, and I'm just focusing on those who are IIT. You see some are quite high, which could relate either to data quality, and I would look at this mainly, probably I'm speculating, but mainly around if a facility uploads a database and not all appointments have been updated, then you may end up with an exaggerated IIT. So your role as a service delivery partner is to work with the facilities. Just make sure that the DP that is uploaded, that all visits have been updated so that we can get a correct picture. When I move to the next slide, you'll be able to see, especially partners and counties who have very good updated EMRs with quite considerable low IIT. And you can be able to see the ranking here by county. You'll also see substantially increased number of those who we have intervened to prevent IIT, which is this column here, close to 19%. And this is the distribution by county. Again, similar numbers when you look at appointments, keeping by partner. Again, just ranking from the highest IIT, see the ones with no partner, and then Migori, CHMT, all the way down to the first set. GIMA for sure at 6.5%. Don't worry, if I move this fast, we'll be able to share this even at facility level after this meeting. And then the second lower deck to give us to a total of 6.7%. And the lowest, which is the county government of Homa Bay, with 12,000 active patients, with just IIT of 1.5%, close to the target of 1% and less. If you see any measure of lost in HMIS, remember this is a site that relates to uploading data to the National Data Warehouse. So I hope you've been able to appreciate the magnitude of the issue and where we can be able to leverage on ML for IIT prevention. So on this second part, I'll just talk on why we need the ML solution and how we can be able to leverage on it. We know in Kenya, we have about 1.3 million people on ART. And we have seen from data of about 1.2 million appointments that more than 70% keep the appointments by either coming earlier or coming on time. And then we have about 30% or 300,000 patients who are missing appointments. They either come back, when you trace them, but there's an issue. And I think the main approach here is how can we leverage on machine learning to be able to tease out this percentage that is likely to be IIT so that we can be able to identify them and implement. Excuse me. Some of you can help me, Thank you. So by just applying a theory of change on how we can be able to harness the ML at the front line, we look at the available inputs and we know the data is there. I'll be sharing shortly on what data is there, but there's quite a lot of data about the client that is available in the national data warehouse. There's also a lot of contextual data or survey data that is available freely that we can be able to leverage on this. We notice we have a resource in Kenya on data science expertise that can be able to do the machine learning models. And we have the program heavily represented today and guidelines that can be able to design interventions once we're able to put these together. And with this, we can be able to put strategies that would largely fall under either ML integration in the EMR. We have been able to build a model integrated in the EML, and we've been able to build flags and reports and alerts that could be helpful in terms of identifying and helping clinicians. For clinical interventions, just leveraging on the program expertise, we can have a preemptive package of care for services. The program has already highlighted the role of, case managers and how they can be able to help, prevent IIT. If we orient the clinicians, then they can be able to implement this, and we can have clinical interventions. We can also leverage on technology, like the SMSs for those who are at high risk or that they are tailored. And what we would expect to achieve is early detection of those who are at high risk of IIT. If we get the alerts on those who are at risk, and then we're able to intervene before the IIT happens, and that way we could be able to achieve the long-term goal of reducing IIT, and our treatment cohort would be growing. And this is what we would want to achieve in terms of treatment continuity. So the value for this model, just to summarize, is just timely intervention, being able to flag and identify those who are at risk. We would get the benefit of resource efficiency, because instead of focusing on 1.3 million patients, we can just focus on a subset, for more intensive support for those who are likely to be IIT. And this would help ultimately improve the quality of care, because it's a component of differentiated service delivery. So the quality of care would improve because you are spending less time for those who do not need it and putting more effort to those who need it. So overall, this is how the picture looks on how we implement the IIT model in the country. So you have different profiles of patients who are visiting facilities. As mentioned earlier, we know the approach has not been standardized for identifying those who are likely to miss an appointment, and therefore this is left at provider discretion. At the national level or county level, it's usually left to epidemiologists and data analysts and MND, SI. Just do manual data analysis, identify profiles of those who are likely to miss an appointment, and then use this to communicate to the program. And at facility level, if we all have this standard approach, then we will end up identifying IIT after it already happened, and we miss the opportunity and end up just tracing them after an appointment is missed. At the national level, we have the National Data Warehouse as the identified data, thanks to everyone who has supported this initiative by ensuring that we have high quality data that is available. And extracting the identified data, we developed a machine learning model for IIT. I'll take you through the process shortly. And with this model, being integrated at the EMR can have benefits because it can dynamically update every new data or appointment data is provided, and can provide feedback to the clinician to be able to intervene for this particular client. At county, sub-national, and national level, we have a solution for public health decision support, where you can be able to risk map hotspots for facilities that are likely to have a higher proportion of clients who are likely to miss their appointments or BIIT, and we can be able to design interventions for this. I'll show you an example. And I'll also be talking shortly about the clinical decision support, what you get at the EMR facility and what you see in Kenya EMR, like these risks, flags or alerts and line this so that we can have targeted approach. And like I mentioned earlier, we can be able to leverage on Ushauri and Nishauri as technology, especially for the SMS-based reminders, so that we can be able to target the high-risk clients. So this is the bigger picture of how we would want to be able to implement this. And as more data becomes available, then we have continuous feedback of updating this predictive IIT model to just improve on its performance. So this is the process of developing an ML model, a standard process. And the IIT model has gone through this entire process. Right now, we're in the process of model performance monitoring. We began by defining the problem, which was to identify those who are at risk based on each appointment that is given. And you would want to predict whether the client or what is the risk of the client missing the next given appointment. And as more data becomes available, then we're able to get, risk profiles updated based on new information. So we worked on the data of about 250,000 patients from the national data warehouse, obviously going through the standard cleaning processes. There's a concept we call feature generation in machine learning. Typically, this is just looking at characteristics or variables that are of importance to the client. And there are two main sources for this. We got about 50 of these from the patient itself, from the EMR. This is patient characteristics like demographics, clinical history, things like that. But then there are also some other information which we call contextual that is available from surveys and other data sources that I'll share later. Then you prepare the data, make it ready for machine learning development, identify what you want to predict. In this case, we want to predict IIT. That's what we are calling our target variable. And then we look at just model training. And this process, I'm over summarizing here because we train more than 350 models. And then we use, machine learning approaches to determine which is the best machine learning model to be able to pick. So after all this, then we ended up picking an XGBoost machine learning model, which is now what is implemented in the frontline. So this is just to appreciate the process that goes behind or under the hood before you will see the risk scores. Just for me to unpack this particular concept of the characteristics that we look at so that you understand how the machine learning model works. Based on literature review, we know there is some information that is more informative to whether a person is likely to miss an appointment. And to look at things like, history of missing appointments or lateness history. And you see most of the data we prepared based on lateness history as presented here has a huge bearing. We also looked at the ART regimen, things like how many regimens someone has been in the last 1 year, whether they are on DTG or not. We look at visit history information, things like whether someone is stable or not, things whether the history of, adherence to ART. And then I also mentioned about contextual variables or features. This is information around characteristics of the facility and the population from where the facility is based. And these are also informative on some of the risk profiles, whether someone is likely to miss an appointment or not. And that's what you have on the extreme right, including facility level, ownership type, the TX car and things like that. And to just bring this closer, we looked at in machine learning what we call sharp analysis, to just look at the weight or importance of some of these features. And I can highlight a few. What we look at is what would relate with current literature is if someone has fewer clinical visits and pharmacy pickups, it means this patient just restarted ART soon. And we know that the risk of IIT is usually higher in the initial phases of ART starting. And what we saw with our machine learning model is that those who have fewer appointments or interactions, they have a higher risk of IIT. Those who have missed appointments, in the last few, appointments based on these criteria we used, we measured by 1 day, 5 days, 30 days. And these are picked from literature, but also are rated arbitrary. we noticed that the more someone is likely to be late for an appointment, the more they are to be at higher risk. And these are some of the features that usually push someone to be able to be considered as high risk. For demographic variables, like you would see in typical analysis, you notice that age is usually a significant predictor. Some things around regimen as presented here. On this other slide, I will just look at whether someone is stable or unstable. And I'm just highlighting the ones that have been picked as, high. So those who are unstable are likely to be pushed. And it's a combination, like I said, this model has over 70 features. So it's a combination of many factors that contribute. And something else that you'd also notice is that those who, even if they keep appointments, those with many unscheduled visits, they also have a higher risk. So this is some of the features that put someone at a higher risk of IIT. Now, we did compare the application of the model with ground truth data, and we picked appointments from 1st of March last year through 30th of January, and we looked at the total appointments given. So this one is based on the data that is submitted to the National Data Warehouse. We had about 1.3 million visits, and 5.5% of these clients became IIT. Again, like I mentioned earlier, you see the country is doing a very good effort to be able to bring back people after they become IIT, but we still have a substantial number that is IIT. But then when you apply the machine learning model, we are able to classify 24% of these 1.3 million visits as high risk and 28% as medium risk. And if you are to differentiate and you would want to focus, just about half or 52% of this medium and high risk is what the country would maybe focus and give a little more effort to be able to help reduce IIT. And this would give you 82% of those who became IIT. Could be able to break this down by partner and county just to be able to appreciate. But this is just ground truthing to just show that the model is able to differentiate those who is high risk and those who is low risk or medium risk for IIT. So in terms of integration in the front line, this is what you see. This, alert system in the EMR, you'll be able to see an IIT risk score. I visited a few facilities, sat with clinicians, and sometimes people do not know what this risk mean. So when it is written as high risk and it's 70%, it just means the risk is a probability from 0 to 100%. And if it's 70%, it just means the likelihood of this client missing the next appointment is 70%. And if you add that score, then you would know that you would really need to intervene for this client. I mentioned about the features that push this client, and you can see the date when this is done and the description that this person has been a recent IIT and they did unscheduled visits. Even though they are optimized and they are stable, they are still at high risk because of some of the features that have been listed there. Something else that we'll also be able to get is you'll get a summary, a line list of the high-risk clients in a facility. And by just working with the facility, they can be able to generate this to be able to know who they need to intervene even before the next appointment happens. And when you have targeted interventions, and I appreciate the care treatment leadership because they have been able to come up with a package of care, and I will be able to project that shortly. Even the appointment reminders, we can be able to target such a client and be able to prevent IIT from happening. I'll also be talking shortly about some of the features that we have received as a request to be able to enhance. So this is the package, the proposed package, for those who are at high risk. So things to do with appointment keeping or appointment management, case management, and also, client literacy, and also DSD. As listed here, I'll not go to the explanation in the interest of time, but we all have this package and we can be able to share so that we cascade these to facilities and across the agencies. Again, for medium risk, what we need to do in terms of appointment management, case managers, at least one minimum session for ongoing patient education, for treatment literacy, and also DST. And for the half of the patients that we say are low risk, then you can be able to provide the standard care. And as more data is collected, the machine learning model can be able to adapt and learn from this to just improve on the risk profiling of the clients. I did talk about above site level for sub-national, talking to sub-counties and counties. So we developed a heat map, just mapping the high-risk regions for IIT. So based on this risk map, just pulling down to Narok and Transmara, can be able to see the overall risk for Narok. And you can see Narok West has a higher proportion, 13% of their patients are considered high risk. So if you're a CASCO, sub-CASCO who is supporting this particular sub-county, you could be able to identify the specific facilities that is contributing to this. And if you wanted to prioritize your resources, then you would want to go to Narok West. If you're in Transmara, where Transmara West has about 0.02 that is considered to be at high risk, you would want to put your efforts maybe at Transmara East. And one of the things that we'll be doing from the national data was to be able to support all the counties and partners is sharing this information product so that you know which facilities to be able to focus on for preemptive action before this already happens. Now, as I go to conclusions that allow for discussion, there's been a couple of reported challenges and just highlighting them here on what we are doing based on what has been reported. So we know there is a missing column in IIT high risk report, and we are updating this to just make sure that we have included this. But we would also want to include the risk scores in the current TXCAR line list so that you can be able to, once we generate, instead of generating a separate report, you could just be able to generate the current TXCAR line list, and then you can be able to identify the risk profiles for the clients who have an appointment. This is under development. It's been reported, I think, especially in the medium and high volume facilities, that risk score generation is taking so long. And sometimes if you terminate before it's finished, then you may end up getting inaccurate risk scores. So we're working on approaches to be able to improve this such that you can limit either the first time risk score generation to the line list of the current active clients, because right now just anyone with an appointment. But then also we're also looking at options for overhauling, our approach for first time risk score generation, or also ways to be able to have incremental risk generation based on appointments given for a certain period. The second part is under design phase, and the solution is not yet available, but we'll be able to share this once it becomes available. We have also received feedback on the confusing nature of the labels for IIT, for PMTCT in care treatment, and we'll be able to rename this and then be able to sensitize the users once this is done. And then we have also seen some users who are still trying to pull IIT risk scores from the national data wells. This used to be the initial process when we started, and we wanted to retire this process of pulling scores from the national data wells, and we need to cascade these to facilities such that they do not need to do this. And then in terms of the next steps, it's based on the feedback again. We need to enhance the EMR to be able to capture when an intervention has been done in response to a risk profile that has been given, and also the intervention given as a package of care based on what I've shared earlier, based on the risk profiles. This will help us, to be able to see whether the interventions are being given and whether we are doing enough to be able to prevent IIT. It would move us closer to achieving the less than 1% IIT that we are looking at. But then it will also help us to improve the machine learning model to be able to use this as part of the feedback. I talked about the public health action and the heat map, that we need to share it with partners and those at sub-national level so that we can implement public health action. And we commit to continually track the performance of the IIT model so that if there's any model drift or there's need for improvement, then we can be able to retrain and release. We also make a request and a running call to service delivery partners and facilities. There is benefit in cascading the training to healthcare providers. In some facilities, there's differential understanding of how the IIT model works and how you can be able to leverage on this. And we encourage partners and facilities to be able to cascade these to facilities. So this request is to partners and counties. Then again, also to sensitize this package of interventions as part of the prevention of IIT or the IFADI project. And then lastly, we would want to just work with facilities to just ensure that they're using the latest version. Without using these versions, you will not be able to get the accurate, risk scores. This feedback that we had received earlier from CEP, and we made amendments to the ML model, and this release for Kenya EMR of those on 2.x and 3.x as projected here. So if your facilities are not on the current version of Kenya EMR, then they may be having the wrong risk scores and they may not be leveraging on what is available. So I think that's the end of what I wanted to present. I'll return this to Songok, maybe to coordinate the Q&A. Thank you very much for listening.
Thank you. Thank you very much, Dr. Mudoka, for that presentation and just helping us understand insights and in-depth of how we can be able to utilize machine learning in predicting clients who are likely to drop off treatment, and of course come up with customized care for those clients, so that we again don't spend lots of resources. Because I know what we always do naturally at the facility level is when a client misses to come to the facility, the first thing that we'll do is to make a call. And in instances where they're not reachable, we may probably plan to do a physical tracing, and that will definitely attract a cost. So if we are able to leverage and use some of this technology that we've developed, then that would really help. It will go a long way in identifying these clients early enough and mitigate the likelihood of them dropping off of treatment. I think what really stands out is what I've already mentioned in terms of the value proposition, in terms of resource efficiency, improving the quality of care for our clients, and of course growing our ART group, or generally our ART cohort. So thank you very much, Dr. Mudoka, for that. I think we have about 10 minutes because we really intend to end this by 3. We don't want to really prolong it that much, but we will allow any questions or any clarifications. Trying to just quickly go through the chat. I'd requested earlier, in case you have any questions, you can post on the chat. We have a team that will be able to respond. I'm not seeing any questions, but just in case you have any comments regarding the presentation, we'll allow you. You can just raise your hand, and we'll allow you to make your comment or ask your question, or seek for any clarifications in case there are any bits that wasn't clear. I think the team is available here to clarify on that. So I don't know whether we have any questions or any clarifications. Yes, I can say Edwin Silma. Anyone else with a question or who wants to seek for clarification? So Edwin Silma, I think I'd seen your hand up, so you can go ahead and mute and probably maybe make your comment or ask your question. I'm assuming that should be Edwin Silma from Narok. Okay. Edwin. Oh, okay. Yes. So Rose Yaboke, you can go ahead. Can the rest of the participants hear me? Dr. Mudoka, confirm if you can hear me. Okay. Can someone confirm if you can hear me, please? It seems that I'm not being heard.
I can hear you from here.
Yeah, I'm worried. Thank you, Kennedy, for confirming. So Nyaboke has difficulty, so let me just yeah. So Agnes, go ahead and unmute.
I can now talk. Good afternoon. Can I be heard?
Yes, Rose, go ahead.
Thank you for the good presentation from Dr. Mudoka. So one of the things that my name is Rose Nyaboke. I work for the USAID Sawisha Pwani as a senior technical advisor care and treatment. So one of the things that I'm interested to see is the prediction. One of the things that I've seen, and I'm talking from the HPS perspective. We have seroconversion at PNC postnatal care clinic at 6 weeks when the mothers who were tested before previously they were HIV negative. But at post-NC clinic, 6 weeks, they're actually seroconverting, and when they get tested, they are HIV positive. So how do we use this now machine learning for those HPS predictions? How can we be able to, the preventive, I know machine learning is one of the game changers just to make sure that we are able to have those ones clients who were screened, there was no risk, tested negative. We also want them to remain HIV negative across the, across the cascade or the continuum of care. So through machine learning, beyond just the HIV program, how do we make sure that from the PMTCT in this global alliance of eliminating pediatric HIV infection, and also reducing or ending HIV transmission rates, how do we make sure that we use machine learning across so that at least we don't have those seroconversions? Because each and every county I've looked at the data analysis, you are able to see actually there are clients who turned out to be HIV positive at 6 weeks. I'm interested in at 6 weeks because that is where that if you don't notice these mothers and you start hey prophylaxis, then you are likely to get a child at 6 months, at 12 months, being HIV positive. So that is what I have. Thank you, and back over to you.
Thank you very much, Rose, for your question, and of course, just going deep to just try to explain and probably also provide some bit of the extent that we could leverage on this. So I will request Dr. Mudoka to maybe make a comment, and then I'll allow Dr. Lazarus to also ask his question. But maybe Mudoka, you could comment on Rose Nyaboke's concern and whether we can be able to probably extend that to PMTCT and more specifically at 6 weeks. Doc?
Thank you, Sangok. Thank you, Nyaboke. So, and I also request, I know the other people in the group will help me respond to these questions, including Dr. Jacob. So for the ML solutions that we have that could be applicable to the PMTCT program, currently, we have the IIT model because these clients are already current on treatment. One of the risk factors that would cause to seroconversion would be IIT. So just leveraging on this IIT model for those who are pregnant and breastfeeding would be helpful to just ensure that we keep them on treatment. And then for diagnosis, especially for HIV testing, because we have a model for HTS, application of the same HTS-ML model in MNCH settings would be very helpful to identify early those who are likely to turn positive, and this would also help with preventing seroconversion. In the pipeline, I know I didn't share this today, but we are currently working on ML model for predicting high viral load. And I think this would also be helpful and applicable to the pregnant and breastfeeding subpopulation. But at some point, And I think this is also discussed during the
Huh?
C for
Ay, muna kola. Imwani araji.
so sorry about that. For the COE for PMTCT, we did agree that the PMTCT MCH program, as more data becomes available, and if they can be able to scale that, then we could be able to train an ML model that would help us to predict maybe, risk of seroconversion. I don't know if there's any other addition, but I think those would be my submissions. But then I could also answer to a question that was raised on the chat about why risk scores would not be available in some of the, I think in some of the facilities that are using 3.x. And I think I did speak to two components in my presentation. One saying that we know that it's taking a bit of time, sometimes in a facility for them to be able to get the right risk scores, then you may need to be patient. The processor needs to be good so that you can be able to generate risk scores for all the patients. But then again, also making sure that the facility has the right version of Kenya EMR, as I mentioned earlier, so that whatever you get, if it's 3.x, just make sure that the facility is using this version, then they should be able to generate. Back to you,
All right. So, yeah, thank you very much, Dr. Mudoka, for your response. We are like 2 minutes to the top of the hour, but I've seen Dr. Lazarus' hand has been up, so maybe I could allow him to maybe also ask a question or seek for clarification, and then we close. Dr. Momanya?
Yes, probably because of time, I just want to comment that this is very interesting, and I think in the facilities I've seen this can be very useful in terms of supporting the clinicians to tailor make the interventions. My quick question was around, I saw where you had mentioned about the time of evaluation. So I wanted to know whether this analysis of risk, is it continuous for the client, or is it like cross-sectional at some point? Or does the risk categorization, is it a continuous process? And then secondly, I wanted to know, so I saw a number of variables that we are using to predict whether the client is likely to interrupt treatment. And I wanted to know whether some of the variables have more weight, are weighted more than others, or how the calculation is done. So thank you so much. And probably because of time, we could continue the discussion behind the scenes.
All right, thanks, Doc. Maybe quickly, Dr. Mudoka, maybe you could respond to Dr. Momanya.
Thank you, Doc. So as you rightly say, the risk scores are generated based on the next appointment. So they are updated. And also, as you rightly say, I think this is what I was explaining here, that these are weighted. So during machine learning process, this is what's called the sharp analysis. Just like the same way you do a multivariable model in a statistical analysis, and you're looking at the effect measure, some will have more weight than others. So based on what we have seen from this, you'll see some variables or some features are considered high, others are medium, and others are low. So for example, the difference between like the duration of appointment given or distance between the last 2 recent visits was a low predictor, did not have a lot of weight. But when you look at the number of times someone or the duration when someone was late by this number, then this has more weight. So that's how the ML model has been able to pick this up and incorporate in terms of making a prediction for you to be able to get that risk score that I was mentioning earlier, like this one.
All right, so thanks, Dr. Mudoka. I think we've come to the end of our webinar. We've stretched a bit, and as we close, probably we'll stretch to about 5 minutes past 3. But I think it's very important for us so that we can give an opportunity to some of our leaders who are here to also just make a few remarks as we close. But more importantly, our take-home messages as part of our next steps. I know Dr. Mudoka had mentioned this, but I think it would be important for us to just stress on them that for us to be able to use this this solution, then it means we need to ensure that we enhance integration to go a long way in improving the efficiency of generating the risk score. So that if we don't do that, then it means it may not really work as we would expect. Then we also need to ensure that we enhance our EMR to be able to capture when the risk scores are being used, especially by the service providers at the facility level. And this goes a long way also in trying to ensure that we manage our clients appropriately. So I think those are the two things that really we need to take home. And having said that, allow me to ask a few of our colleagues who are here to just make a few remarks as we close. Allow me to begin with Dr. Jacob. Maybe can say hi to the team and maybe quick remarks as we close. Dr. Jacob.
Yeah, so thanks, Songok. Maybe just to appreciate the team for joining this call. We know that this is like only the second model that we have built into the EMR. So we are expecting that we learn as we grow with the model. Just two main comments. So the first one is with regard to the PMTCT that someone mentioned earlier. A person who can transmit HIV to their infants is someone who has HIV. So which means that for the PMTC program, a good starting point would be to leverage the models that have been built, like Dr. Muthoka mentioned, to look for women who are at risk of seroconversion. I know the PMTC guidelines require that they should be tested a few times, but during that testing process, you can probably be doing a risk assessment for the mother so that you can be able to identify the ones that are high risk of transmitting of seroconversion. The second is that for those who are already positive, we are able to predict those who are likely to fall out of treatment. There's an analysis we did earlier this year, and we found that cycles of treatment interruption is associated a lot has some association with the seroconversion. So which means that by averting IIT, you can actually prevent MTCT during the PMTCT setting, both during pregnancy and breastfeeding. So those are very initial use cases that you can apply the machine learning to prevent MTCT. We hope that in the future, we are going to build a PMTCT machine learning model that combines both the maternal risk factors, general HIV risk factors, and the pregnancy-related pregnancy and breastfeeding factors, so that we have a robust model. But for that to happen, we need as much data as possible from facilities that are using the MCH and the HIV treatment module. The second broad comment that I wanted to make is that machine learning solutions on their own cannot avert IIT. We need to learn from the program of how they would like to act on the risk scores that have been provided. And I know that the program has suggested some indicators. We'll be looking for feedback from you on how to incorporate those in the EMR, so that one day when we are evaluating whether this model is working for you or not, we can be able to determine whether the model was actually used to offer interventions, and then give you feedback on whether those interventions are working. Otherwise, I think we are very happy to collaborate with you. Feel free to reach out to us for feedback so that we can continuously improve the solutions that we have provided. I'll give it back to you, Songok, for more remarks. Thank you.
Thank you. Thank you very much, Dr. Jacob, for your comments, and also just highlighting or giving us some insights and how we can also leverage on what is already existing to be able to respond to some of the concerns from Nyaboke. And I'm sure what Nyaboke raised could also be in the minds of most of us who are here. So thank you very much, Dr. Jacob, for those comments. So I wanted to request anyone from any colleague from DOD. I know I'd asked earlier. I don't know whether they've been able to join us. Anyone from DOD, you can unmute and just say hello to the team and make remarks. Anyone from DOD? Someone had unmuted at some point. Okay. USID, Lydia, your particulars. I know you've spoken earlier.
Yeah, thanks, Songok. Just to thank the team, the Palladium team and NASCOP and everybody involved in this initiative or feature. I think it's a very good one in averting IIT in a proactive way than just waiting to the end and then we start being reactive to the occurrence of IIT. So just saying thank you to the team, and the facilities and partners can then focus on the use and just the utility is what will show us that bring back the results and just avert the IIT as needed. Thank you.
Thank you very much, Lydia, and we also appreciate the support that is coming from your end as the USAID fraternity. And I think, as Dr. Mudoka had mentioned earlier, we'll be able to share this, and the purpose of us sharing this analysis is just for targeted follow-up. It is up to the facility level. So thank you very much for those remarks. So moving on, I want to request, I know Dr. Kimanga has also joined us in the call, but first I want to request Dr. Agnes probably to make a few remarks. Then Kimanga will come next. Dr. Agnes.
Thank you, Songok, and thank you, Kennedy, for the presentation. I think for me, Rose actually highlighted the key things that some of us are hoping to see in the coming future. And I think my only request is just to continue urging the support that we get from the facilities, just to ensure that the quality of data that goes into the national data warehouse is of standard, so that as we continue to build these models and actually see what it is that is happening, then we are sure of the analysis that we are getting, and we know that the analysis is covering 100% of the clients that we see and not a percentage, just because we're not putting in 100% of the data. Other than that, thank you so much for this webinars. They're very helpful. Thank you.
Thank you very much, Doc, for your comments, and we also appreciate the support that we do get from your end. So I want to request Dr. Kimanga to also make his remarks, and meanwhile, I'll be looking out for any county rep to also speak on behalf of the counties. Then Dr. Lazarus from NASCOP will be able to close for us the meeting. Dr. Lily, again, let me mention, Dr. Lily wasn't able to join us because she was called to a very urgent meeting. But we have our blessed. She joined at some point, but she wasn't able to speak because she was called again to join another meeting. So, Dr. Kimanga, over to you. Sorry, did Dr. Kimanga drop off at some point? Dr. Mudoka, confirm if Dr. Kimanga is still in the call. Sorry, I'm not trying to see.
I didn't see him on the call. I don't know.
Oh, yeah, it seems like he dropped. Okay, anyway, thanks. It's okay. Oh, Mangi, Daniel Mangi, probably you could make a comment. I know Kimanga has dropped, but you can speak on behalf of the SIT CDC.
Hi, Songok, you can hear me?
I can hear you, Dan. Go ahead.
Oh, okay, thanks. I know Dr. Kimanga was in another meeting, so perhaps I went back there. But good afternoon, everyone. Mine is really to thank you for joining this webinar, whereby we have really focused on how we can leverage machine learning to prevent treatment interruption. I also want to thank you for your active participation and the additional requests, especially for on PMTCT. So we have noted that. So I also want to appreciate NASCOP's leadership through Lars, Dr. Lily, Songok also for convening this webinar, and the Palladium team for not just for the presentation, but also the work that you have done in terms of model development and deployment. Actually, without data, this model would not have been developed. So in one way or the other, all of us have been involved in the development of the model. I also want to echo what Dr. Jacob said. The model alone cannot solve the treatment interruption problem. So we really count on service delivery partners, for your active engagement, really to ensure that, this technology is not just adopted universally, but also, integrated in, within our existing frameworks. So ML development is really, a continuous process. So your insights and feedback, I think, will be very, very important as we continue to refine and improve the model. Once again, thanks for joining the call, and back to you, Songok.
Thank you very much, Daniel, for your remarks on behalf of the SI team at CBC. I don't know whether Kate Mary was able to join from the PCO or anyone from PCO. I really don't want to leave anyone out. Kate Mary, I don't know that you managed to join. Okay, fine. So I really don't want to belabor too much on what all the speakers have said. Mine is just to most sincerely appreciate everyone for finding time to attend our webinar. Please look forward to our next webinar, which will be the third one, which will come up on July 2nd. Remember, we said we promised that we'll be sharing with you various analysis from the National Data Warehouse, and on 2nd July, we will attempt to provide some insights from individual level data and focusing majorly on NCD management. Again, remember that will be heavily relied on the data that is in the National Data Warehouse. So as we upload our data for this coming month, let's ensure that the data, all the variables are complete, the databases are complete, in order for us to be able to provide some rich analysis and probably come up with some pointers in terms of what kind of decisions do we need to make the data that the National Data Warehouse, and more specifically on non-communicable diseases. So having said that, allow me to welcome Dr. Lazarus Momanye to make his remarks on behalf of the NASCOP team and also close the meeting for us. Over to you, Dr. Momanye, and thank you from me.
Thanks, Songok, and mine is, of course, also just want to appreciate the team that put together this very interesting and a very insightful analysis. So thank you, Songok. Thank you, the team from Palladium. Thank you, Dr. Ken Muthoka, for the presentation. Also to thank the people who participated. I think we're over 300 people on this call. And it's very interesting just to see the level of interest. So mine is just to echo what everyone has said, that I think machine learning presents a very big opportunity for us, and also knowing that we have a very rich database. And compared to a number of countries, actually, we are way ahead in terms of the coverage of our EMRs and the data that we have on the National Data Warehouse. So we are looking forward to continuing working with you. And I think from the care and treatment program, we even look forward to a scenario where we'll actually even be asking for this kind of analysis. And even, I know you've spoken about NCDs. How can we be able to predict people are likely to have comorbidities and be able to put interventions to prevent before they contract the comorbidities and so on. So just to thank everyone on the call and to look forward to future such kind of interactions and that kind of webinars. I do hope that in the next course, we can also have more of the count people, the CASCOs, the SCASCOs, and also the care treatment technical teams to participate with the national program to join the course. So thank you so much. Have a great day. And the meeting is closed. Thank you so much.
Thank you, Doc. I think I need to make some bit of a correction. Our follow-up webinar actually should be on service delivery practice in tracking AHD, which should be on June 4th, not July. Apologies for that. And please mark that. We'll also be sending you a reminder to the same. My sincere apologies for the mix-up. Thank you.